thing, and I think I would just give the floor to Dr. Jessee to give his presentation. You've been aware that I have been standing here. That is because I felt a little dizzy after an hour of sitting in a chair, so I used the opportunity. You stay there, and he will say something. Oh yeah, you take the other one.
Thank you, Evert, and thank you all for your participation and attendance in this rather momentous occasion 30 years after Udine hosted the formation of the International Society for Quality in Healthcare. I am now, I'm thinking 43 years past the time I completed medical school. And in my 43 years in the profession, most of which has been in administrative roles in various organizations, one of the major trends has been that the volume of information, the volume of knowledge about healthcare, medicine, nursing, all the other health professions, disciplines, has grown exponentially. And at the same time, medical specialties have become more and more subspecialized, narrower. There's been a proliferation. When I started medical school, there was no such thing as a respiratory therapist. There is now a whole profession of respiratory therapy, and there are many other disciplines that have emerged. Some pundits have said that what has happened is that we now know more and more about less and less as we become more specialized. And at the same time, our patients have become more complex, and there is more and more of a need for teamwork. So we have something of a divergence between the hyper-specialization that has occurred and the need for, as care has become more complex, more technologically sophisticated, the need to come together as a team and try to figure out how can we focus on the patient, not just on their heart, not just on their lungs, not just on their musculoskeletal system, but on the patient as a whole, and try to treat their illnesses most effectively, but also, perhaps even more importantly, to keep them healthy and keep them out of that acute care hospital. That has become much of the focus of quality improvement efforts in the United States. The hot topic right now is population health management. If you go to a conference in the United States, almost invariably there will be something on population health management. And yet we still have a care delivery system that is very much focused on acute illness. And that, I think, is going to be one of our major challenges going forward. Someone mentioned earlier today that hospital management historically was done by physicians. And then they often, I think, Charles, it was you that said that they often knew nothing about managing an organization. Well, that was fine in the 30s and 40s when hospitals were not very complex places. But as the hospital became more complicated, there was a greater need for management expertise. And again, using the U.S. as an example, prior to about 1940, virtually every hospital CEO was a physician. Then in the 40s, we began to see the emergence of master's programs in healthcare administration and the training of individuals often without a clinical background in the managerial aspects of running hospitals. So that by about 1970, it was extremely rare to find a physician CEO in a hospital. The pendulum is now swinging back the other direction. We're now seeing more and more physician CEOs in hospitals, but many of them have got a second degree. They have either an MBA, a Master's in Business Administration, or an MHA, a Master's in Health Administration. So they bring both the clinical perspective and the managerial skill that is really important in running a healthcare organization. What I'm going to talk with you about today is a specific educational program designed for those senior healthcare leaders to help them have in-depth knowledge about quality, because if you ask who is responsible for quality in a hospital or health system, and the answer is everyone. but it has to start with the leadership of the organization. You heard that from Elma Heidemann. I had one of my students once ask me whether the best way to develop a rigorous quality improvement program was top-down or bottom-up. And my answer was yes. It has to be both. You can't have the frontline people trying to improve quality without leadership support from the top. And if you simply have a top-down edict, I think Charles pointed that out in terms of some of the former Soviet Union republics, it's often greeted as just another thing that keeps me from doing the work I have to do. And there is very little enthusiasm for actually engaging. So to me, the ideal approach is to have that top-down leadership combined with bottom-up expertise. And who are the people who know where the problems in quality are? They are the frontline caregivers. They are those that are most in touch with what needs to be improved. So I think the challenge for those of us in education is to find ways of creating, Andrea has used the term integration, better integration of the disciplines. Medical education still is largely in a silo where most medical students have no idea what nurses are trained to do or what pharmacists are trained to do. They may pick it up through their interactions, but there are very few opportunities for crossing those disciplinary lines during the education process. And quality may be one place, not necessarily incorporating it into the curriculum, but trying to create interaction between nursing students, pharmacy students, medical students, with role modeling by their professors to engage in learning more about how they can work together to improve quality of care. All right, that's background. You may find this hard to believe, but as I sit here before you this morning, I am teaching a class at the University of Alabama in Birmingham, Alabama. The way I'm doing that is because when I go back to the hotel, I go online and interact with my online students. Next week, I will be in Birmingham, Alabama for a face-to-face week with those students. The degree program is an executive program for mid-career healthcare executives. It leads to a doctoral degree, a doctorate of science, which is an applied doctorate, requires a dissertation, but it is not a research degree. It is not a PhD. It is an applied doctoral degree. It's offered by the Department of Health Services Administration at the University of Alabama in Birmingham. The program has been in existence for perhaps 15 years. And historically, that department has had a very strong master's degree program in health administration, but they started the executive doctoral program in response to many requests for an advanced degree. It's normally a 3-year program, culminates in a doctoral dissertation and defense, and is a blended format of face-to-face and online interaction. As an executive program, all of these students have jobs. So this is something that they do on top of their job. I will tell you as a faculty member, that is a wonderful thing because they are committed. They are not young, fresh out of undergraduate school, trying to find something to do other than go to work. They are people who understand that the additional education is of value to them in advancing their career and doing a better job in their work. And in many cases, their tuition is being paid by their hospital or health system, who is their employer. The course that I teach is called Healthcare Quality Improvement. It's a required course in the doctoral program, and it has a duration of 14 weeks. The first 4 weeks are exclusively online. And during the online sessions, they have a number of readings to do. They have case studies to analyze. And each week, they have to respond to questions about their case studies in an online dialogue. And as the faculty member, my role is to encourage them to interact with one another, but also to respond to some of the points that they raise during the online sessions. Week 5, which will be coming up next week, consists of 20 hours of face-to-face instruction on campus, 5 days, 4 hours each day. By the end of the 5th day, they are brain dead because that is a lot of face-to-face instruction over a short period of time. but it is the real opportunity to take some of what they've done in the online work and then have an opportunity for face-to-face interaction. Then the last several weeks, weeks 6 to 14, are online again. The class currently is composed of 20 students, and I've taught this class every other year for the last 6 years. Typically, the class size is around 20 or 21. Several of them are hospital or health system CEOs. The average age is about 40. Others are senior executives, chief operating officers, a couple of chief nursing officers. I have 2 university faculty members who are in the current class. One is from a university in Saudi Arabia. The other is from a university in Pennsylvania. I have a couple of medical practice executives, people who are managing physician practices but not in the hospital. And there are several in this class, which is somewhat unusual, who are consultants. I suspect that in some cases, when you say you're a consultant, that may mean you're between jobs, that you used to be an executive. You currently are not in that role, so you're doing consulting, but your intent is to become an executive again. I know this is a bit copy dense, but I will read it to you. This is from the syllabus. It gives you a sense of what this course is intended to do. The course is designed to give healthcare executives and leaders a working knowledge of policy issues and managerial methods related to the quality and safety of healthcare. It will briefly trace the history of quality improvement in healthcare and explore both public sector and private sector approaches to quality measurement and improvement. While several specific quality measurement and improvement methods will be explored, the major focus of the course is on the role of senior executives in creating and maintaining an organizational culture in which quality improvement and safety initiatives can flourish. And I will pause here because I think you've heard several of those phrases from other speakers this morning. The role of senior executives in creating and maintaining a culture in which quality improvement and safety initiatives can flourish. That's what the leadership role is all about. The role of the organization's governing board, senior managers, and physician leaders in quality improvement will be emphasized. Tools for culture assessment and methods of change management will also be explored. Case studies and exercises centered around improving organizational performance on Medicare reportable quality measures. We have mandatory reporting to the federal government of a certain number of quality measures from every hospital that accepts Medicare, which is essentially every hospital in the U.S. And those will be used to illustrate principles and methods discussed in the course. Key policy issues related to quality measurement and reporting, patient safety, and financial incentives for quality improvement will also be discussed. So that gives the students up front an idea of what it is, what the expectations are from their participation in the course. One of the requirements for everything these days is accredited. Not only hospitals, but laboratories, medical practices, and education programs. And this program is accredited by the Commission on Accreditation of Healthcare Management Education. And one of the requirements for that accreditation is that there be explicit course objectives for every course. So there are a set of, I think, 6 objectives for this course. Upon completion, students should be able to develop, lead, and manage effective programs for quality improvement and patient safety enhancement in hospitals, health systems, and medical practices. They should be able to analyze data on healthcare quality, efficiency, satisfaction, and safety, and identify opportunities for improving organizational performance. They should be able to lead the redesign of patient care processes and other production processes to make them more efficient and effective. They should be able to effectively participate in the formulation and implementation of public policies for improving the quality and safety of healthcare. They should be able to develop board and physician leadership support for quality improvement and lead efforts to create an organizational culture in which quality is one organizational priority. And lastly, they should be able to lead efforts to measure, assess, and improve organizational performance on aspects of patient care quality that are the subject of public reporting. As with any course, one of the most interesting challenges is finding a textbook that addresses what you would like to address in the course, and this is the one that I'm currently using. This one is published, I believe, in 2012 or 2013. It's a second edition of an earlier book by McLaughlin and Kaluzny. It's called Continuous Quality Improvement in Healthcare. I think it's a very comprehensive text. If any of you are contemplating teaching students, whether they're managerial students or clinicians, I would suggest that this is a good textbook to use. A quick aside about what a small world it is. The second author on this is Julia Johnson. And Julia Johnson is a graduate of the University of North Carolina. She took an MPH there and then did her PhD at the University of North Carolina. I was at the American Medical Association as their vice president for quality in 1996 through 1999. She approached me about serving a summer internship with our office in Chicago because I had formerly been on the faculty at the University of North Carolina. So we hosted her as a summer student when she was doing her master's program. She then went on, completed her PhD, got married to an anesthesiologist, and they moved to Sydney. And she took a faculty position at the University of New South Wales. And I sort of lost track of her until the ISQUa meeting in Paris in 2010, where I bumped into Julia Johnson, who was still on the faculty at the University of New South Wales. She published this textbook and is now a professor at Northwestern University in Chicago. So it's fascinating how small the world can sometimes be and who you bump into that you wouldn't least suspect to see some years later. Excellent textbook. They wrote a companion book called Implementing Continuous Quality Improvement in Healthcare, a Global Casebook. And this is a series of case studies of hospitals, not only in the US, but in other parts of the world as well, that have identified a quality improvement opportunity. And they're quite candid case studies because they talk about what worked, what didn't work, and then each of the cases concludes with a series of questions, which I use as part of the online instruction to get the students engaged with thinking about how might I have done things differently? What can I learn from this case that would help me do better the next time? And what did I learn from this case that I really want to record as a successful strategy or tactic? Then the third book that we give them, and this is not required, but it's highly recommended, it's a book called Transforming Healthcare. And it's a case study of one institution that has really focused on quality and safety as its reason for being. Virginia Mason Medical Center is in Seattle, Washington, and it has gained a rather substantial reputation as a center for quality and safety. And this is a very nice case study of their journey, some of the things they did. I'll just give you one quick example from the book. They were building a new cancer center. They're going to build a brand new facility. They have a very strong oncology program. They had actually gone through the design phase and had spent probably $200,000 or $300,000 on architects' fees for doing initial design for the building, when someone said, "I wonder how patients will react to the new facility." And you know, we often pay lip service to patient-centered care, but like many places, this had been done as an in-house project without really bringing any input in from the patients who would be most affected. So they brought in a number of their former oncology patients, went over the plans with them, and threw them out. They basically decided that it was better to sink the cost that they had already put in and redesign a facility that would be more patient-friendly than the facility that they had initially planned. They've now built that building, and it is very well received by patients. It's interesting, it required some of the nurses and physicians to change their workflow because we often design physical facilities more around the health professionals than we do around the patients that they serve. But I thought it was a very good example of actually practicing what you preach when you talk about patient-centered care. The work consists of weekly reading assignments from the text, plus journal articles and other resources that are available to them online. The expectation is about 3 to 5 hours per week for this course. They typically are taking 2 courses at any one time, so they've got a 6 to 10 hour expectation of work on their degree. And remember, these are people who are also working full-time as well. They have 6 weeks of assigned case studies for online discussion. They have to write 3 short papers on assigned topics. And then their final capstone project, in lieu of a final examination, is making use of the tools they've learned in the course to carry out a quality improvement project in their own organization so that they can actually get some experience in working with those tools. In many cases, they know that they have a quality department, but they've never personally been involved in any quality improvement activity. This is just for your information, the way I assign the grades. 30% of their grade is based upon the written exercises. 10% is based on campus presentations and discussions. 30% in the online discussions. One of the things I've learned about online education is you need to put a fair amount of weight on the stuff that is assigned online because it's easy for people to ignore that if it's not weighted fairly heavily. Well, there's nobody here. I'll come on at the last minute and participate in the discussion in a perfunctory way. So I place a fair amount of weight on the online discussions. And then a big part of the weight is the final report, 30%. Some lessons learned in teaching this now for the 3rd time. Mid-career executives are generally highly motivated to learn how to better lead QI initiatives. In most hospitals in the U.S., there is a substantial investment being made in quality, often to meet Joint Commission requirements, but also because we now have public reporting requirements for Medicare. Many of the health insurers require certain quality data to be collected and reported to them. The amount of money that is spent on quality measurement is quite substantial. In some cases, the value that's received from that expenditure is not good because there's a lot of data collected, but often not much use is being made of those data other than to report to external agencies. So these executives are generally highly motivated to learn how to get better value out of the money they are expending already on quality improvement. Sharing their own experiences creates a rich learning environment, both face-to-face and online. Frankly, as someone who has been involved in education for a good part of my career, I much more enjoy this kind of an executive program than I do the graduate students who are fresh out of undergraduate work and don't know much about the world yet. These people know a lot about the world. They have a lot of experiences from their own organizations, and it's a very rich environment, and they're all there because they want to be, which is a very, very important characteristic. The soft skills, culture, conflict management, motivating others, stimulating self-discovery are probably more important than the technical skills such as Lean and Six Sigma. They will have technical experts on their staff that can do a lot of that work, but it's the leader really needs to understand how to shape the organizational culture, how to surface and deal with conflicts, how to create motivation, and to stimulate self-discovery. One thing about physicians is that we are very curious people. And if we can be motivated to try to understand more about why is this the way it is, what is going on here, we often will take the ball and run with it. So part of the challenge is to find ways of self-motivating individuals and stimulating self-discovery. And finally, making quality improvement a responsibility of the top executive and clinical leaders, not just a staff support function, is vital. I mentioned with my colleagues yesterday that one trend that has happened that I've been concerned about is many hospitals now have an individual designated as the chief quality officer. And unfortunately, that often sends a message to the frontline staff and the physicians that, oh, good, they'll take care of that, I don't have to. And I think that's something we need to be very careful to avoid, is creating the impression that we have somebody who does the quality stuff, because the quality stuff really needs to be something that everybody plays a role in, frontline staff as well as leadership. And that concludes my presentation. I did give Dr. Gardini a copy of the syllabus for this course, so if any of you are curious about that, he can provide you with a copy. Thank you again for your attention.